Good morning, everyone. I'm Nick Hill. I'm the Senior Informatics Director at the Great Plains Tribal Health Board, and I serve the Tribal Epidemiology Center, aka Great Plains Tribal Epicenter, GIPTech. I built GIPTech's informatics program from the ground up and have had the privilege of setting the vision for the team behind what you're about to see.
And I'm Ryan Berger. I'm the Senior Product Manager at the Great Plains Tribal Epidemiology Center. I came to this work through a placement with CDC Foundation, one of 4 placements currently embedded with the Great Plains Tribal Epidemiology Center. And I spent the past year and 3 quarters on the ground with this team under the CDC Foundation's Workforce Acceleration Initiative grant. My background is health IT, not epidemiology, and Nick's team brought me up to speed fast. I now lead customer engagement and product management for the platform you're about to see.
Before we get into the slides, Ryan, a lot of folks watching this have never run into a CDC Foundation placement before. What does that actually look like day to day?
Great question, Nick. The Workforce Acceleration Initiative places early and mid-career professionals like me directly inside health agencies, in this case, the Great Plains Tribal Epidemiology Center. For an extended embedded term, I sit with your team full time. I wasn't epi trained going in, and so the first few months were a steep climb, learning what epidemiology was all about. But the model is built for this to bring folks with product and technology skills that are hard for an agency of the Great Plains size to hire directly and pair them with the institutional and clinical knowledge that's already there. So let me turn that around to you, Nick. You've been at this a lot longer than I have. What got you building an informatics program here in the first place?
Well, so I watched the gap firsthand, especially during the COVID pandemic when we had limited access to data, infrastructure, and systems. We had no optics into the impacts that COVID was having on our tribal nations and communities, and yet we're being asked to provide that. And I spent years seeing small public health authorities, especially tribal nations, carry real disease burden with none of the tooling that larger state health departments take for granted. At some point, you just stop waiting for someone else to build it for you and you move it forward.
Great. Thanks, Nick. And one housekeeping note before we get going. What you're watching is a recorded session, not a live demonstration. The system walkthroughs you'll see in a few minutes are screenshots that we captured ahead of time. Everything on the screen during those segments is test data, synthetic records that we generated and loaded specifically for this recording. So there's no real patient or case information in this presentation.
Good to say, Ryan. Let's get into it.
Let's get into it.
Okay, this is who we serve, including 17 tribal nations and a major service unit across the Great Plains through the Great Plains Tribal Epicenter. Everything you're about to see was built with and for these nations and communities.
For folks who aren't familiar with the Great Plains footprint, what does serving tribal nations across the Great Plains actually mean in practice? Are we talking about one health system, one tribal epidemiology center, or many?
One tribal epicenter, many systems and nations, and we call them tribal communities. Sometimes we refer to them as tribal nations because they are their own sovereign government, each with its own health priorities, its own leadership, its own relationship with us. We don't get to treat one homogenous customer base like everyone fits through one view or one lens. Each governance decision, every data sharing agreement, every piece of this platform has to respect that there are many sovereign nations at the table, not one, and each has their own distinct voice.
And as we go through this, you'll see that is going to come up again and again as we talk about the platform and how we designed it and how it was built. It takes that sovereignty into account and takes advantage of the scale of bringing everybody together, but also allows us to really keep all the data separate.
Yep, that's exactly right, Ryan.
I spent my career watching smaller public health authorities carry the heaviest disease burden with the weakest tools. During COVID, American Indian and Alaska Native people died at 2 to 2.5 times the rate of white Americans. The life expectancy gap between our communities widened to 11 years by 2021, which is up from 7 years just 2 years earlier. And as of late 2024, fewer than 45% of critical access hospitals nationwide even had modern electronic case reporting in place. And those numbers are hard to sit with, Nick. You lived through some of it directly. Can you walk us through what actually happened on the ground in 2020? Yeah, sure. When COVID swept through the Great Plains in the spring of 2020, test and case reporting data was non-existent for the tribes. Many dashboards lacked reporting race and only report cumulative cases at the county level. These were available only through state and federal agencies. GIPTech harvested and aggregated publicly available data from typically weekly posting on state and these federal dashboards. We did the near impossible task of trying to interpolate and estimate risks down to the tribal communities that were asking for this. Lacking data on them meant lack of lives being saved. And it wasn't an isolated failure. A 2022 Government Accountability Office review found that tribal epicenters still cannot reliably access the CDC and IHS data that we need to track in our own communities. Hampered by the lack of data and system access, we also had a shortage of data scientists and supporting informaticists that larger health departments typically take for granted. So can you walk me through that a bit more? Is that just a technology gap or is there a workforce piece too? Oh, it's actually both. And they compound each other. The technology gap means the data sits in systems that don't talk to one another. The workforce gap means that even when the data is technically available, there often isn't anyone on staff with the bandwidth or specialized skill set to build pipelines to get it out. Same with the transformation of data into meaningful actionable reports. The small and tribal public health authorities get hit by both at once. And while larger state systems have mostly solved the technology problem years ago and can hire dedicated staff really to meet the rest. And just before we move on, you say the largest state systems. What's the gap in capability that we're actually talking about? First of all, I'd say data access is number one. Automated lab and case reporting, deduplicating persons and case records across the jurisdiction, cleaning and analyzing data, and real-time dashboards. These are the basics of a well-funded state health department that began probably 2 decades ago after the SARS-CoV-1 scare and decades of bioterrorism funding. Most tribal epicenters have had access to none of that, no funding and or resources. So when we talk about modernizing surveillance, we're not just talking about new software. No, we're actually talking about closing a structural gap that's been there for decades. COVID just simply made it impossible to keep ignoring this fact. And that's exactly what we're trying to, and that's exactly the gap our platform exists to close, giving public health authority of any size the same real-time visibility into disease spread that the largest state systems already have. And that's what we'll show you today.
GIPTEC is one of 6 departments within the Great Plains Tribal Health Board and one of just 12 federally designated tribal epicenters across the country, which are designated as under federal statute to support American Indian and Alaska Native communities, tribes, tribal organizations, and urban Indian organizations. GIPTEC is the public health arm of our organization with the public health authority as defined under HIPAA.
So Nick, for folks who aren't familiar with how tribal sovereignty intersects with something like HIPAA, can you unpack that a little bit? Why does it matter so much how winter count gets built?
Sure. Yeah. Well, tribal nations are sovereign governments that predate the United States. Under HIPAA, they're recognized as public health authorities in their own right, with independent legal authority to govern their own health data and people. That's not a courtesy, it's the law. And our data governance here is grounded in tribal resolutions and overseen by a tribal advisory council that make up of the health directors and health chairpersons of the Great Plains tribal area.
So when a tribe says this is our data, that's not just a policy preference that we're choosing to honor, correct?
Absolutely correct. The Tribal Health Board isn't ceremonial. They review and weigh in on real governance decisions about how data moves, who can see it, and under what agreements. Unlike state and local health departments that derive their authority from state and local statutes, Great Plains Tribal Epicenter Public Health Authority comes from the Tribal Health Board resolutions that are passed by the 17 tribal nations chairpersons. That sovereignty isn't a footnote for us. It is the foundation of everything else that this is being built on.
And just to go a little bit to the side here, we're talking here about the information infrastructure, but can you talk a little bit about how that tribal sovereignty has interacted with state laws and local data sharing as we talk to different states, when we talk to different labs about how they choose to honor that tribal sovereignty and public health authority?
Well, broadly, it has not been honored. And the problem is a misunderstanding of public health authority on the part of the state and federal and local health departments. Tribal nations and the tribal epicenter have public health authority, and it essentially enables them and empowers them to collect data on tribal members, surveil, perform public health practice, including investigations, contact tracing, interventions, follow-up and care, and so forth. Linkage to care is an important function that really needs to be enhanced and augmented in the public health domain of tribal nations. So it really has to do with ensuring that state, well, from federal down to the local levels, that all of the other public health agencies are understanding tribal public health agency with a capital A as well.
And so I just asked that question. So what we'll see today, we've really built this system thinking forward to future data use agreements and future access to data. We want to give the technical capacity to honor the data sharing agreements that we're still working on today. So thanks for that background, Nick.
For years, the systems on the market simply were not built for agencies like ours. They're just simply too expensive, too rigid, and impossible to sustain through grant cycles and staff turnover. And they're also quite monolithic. There are separate systems for reportable conditions, vital statistics, immunizations, injuries, and the like.
Yeah, and that's the product challenge I was handed. Build something a small sovereign public health authority could actually afford, adapt, and keep running. So we ran a 9-month selection process looking at commercially available and so-called free tools, including EpiTrax and the National Electronic Disease Surveillance System, while also building a prototype ourselves to see whether we could do something better and cheaper.
So, Ryan, you looked hard at both of those before we built anything ourselves. What specifically told you that they would not work for us?
A mix of things. The commercial options carried licensing and implementation costs sized for state level budgets, not a tribal epidemiology centers. The free options solved part of the problem, but came with rigid workflows that weren't built to flex around tribal data sharing agreements or sovereignty requirements. And also, they were built on older technology, so they just simply don't operate efficiently. And both these categories assume the level of dedicated staff that the smaller agencies like ours just can't guarantee across multiple grant cycles. None of that's a knock on these tools. They just weren't designed for an agency like GP Tech and for modern cloud-based architecture that's available today.
Hmm. Yeah, and so the prototype that we started building was not a self-inflated idea that we're just going to build our own thing. It was part of an open and reflective assessment of all options, but it was the only option that actually fit.
Exactly. Okay. Well, this is Winter Count, the platform the team at Great Plains Tribal Epidemiology Center built. It's got a secure sign-in that houses everything that the tribal health leadership needs to monitor and investigate cases in their communities.
And the name is intentional, Ryan. The winter count is a traditional Lakota and Great Plains tribes historical practice, a painted pictorial record on animal hides kept year after year of the events that mattered most to a community. Our executive management at our health board adopted this name for the surveillance system after that tradition on purpose, because this is a contemporary and modern way of keeping the community's events recorded, a winter count. Someday this system too will only be logged in historical archives as an ancient system with ancient practices, but these will be foundational to the future health and well-being of the Great Plains area tribes and their sovereignty in reaching and achieving that status.
Yeah, the Great Plains have always been working with data, and this just carries it forward. So 5 principles drove all our decisions. First, the cloud native design. We chose Microsoft Azure and Fabric, but could be any cloud system. A user-centered design, modular architecture, governance first, and agile delivery. So we were able to validate with stakeholders before we expanded the scope.
And every one of these were tested against a single question. Could a cloud native modular architecture give a public health authority or agency like ours something low cost, scalable, and user centered that also is sustainable, secure, and replicable across other agencies? The question came directly out of years of watching what didn't work.
So Nick, this is a question I get asked most by other jurisdictions, and I want to make sure we answer it. We've talked about agencies that move to workloads to the cloud and watch their costs spiral out of control, well past what they budgeted. Why hasn't that happened to us?
I think a few deliberate choices made the difference, Ryan. First, we leaned on managed services over custom built infrastructure wherever we could. This meant fewer servers and processes for our small team to babysit. This lowered the entropy and meant fewer surprises and higher success levels on multiple fronts. Second, almost everything runs on serverless microservices in a consumption-based pricing model. This means that we're paying only for actual use and only for the time that we're using it. Processes are not taking capacity while sitting idle around the clock. And third, we adopted modularity, which means we didn't turn every component on at once, but grew capacity in support of defined express needs. So costs grew at the pace of adoption and not ahead of it.
Yeah, it's really just as an example, we see that we don't use very many resources. We turn it off after hours, and it only turns on when we need the system. And then when we have a big data load or a big analysis, we're able to scale up quickly, get it done, and then shut it back down. So it's architecture, but it's also discipline and really managing the way we build out the analytics, the way we build out the data pipelines and the application so that it really takes advantage of that web-based architecture from the get-go. Is somebody actually monitoring the meter month to month?
Yes. actually, architecture will get you most of the way, but we also built monitoring and accountability into how this team operates. And no one on this team would tell you cost control happens automatically. It happens because we were mandated to be intentional about cost control and sustainability. This allowed us to make continual process improvements with right-sized performance while minimizing the cost. It was actually beautiful to watch the team attack this from every angle possible.
Yeah, I'm just recalling the time that we launched a new analytic tool, and it started really spiraling out of control. And John, I mean, it didn't spiral out of control because we had the brakes in place, but John jumped in and said, turn it off," and then we had to go back and re-architect that solution to really not be so wasteful and expensive. And so I think it's that real attention to detail and efficiency that the team has that allows us to continue building more capability, growing the system, but not growing the costs exponentially.
Mhm.
So 5 pieces make the system run. There's an automated ingestion pipelines to pull in lab and case reports and any other data that we need. That's electronic lab reporting, electronic case reporting, other data sets using HL7 and proprietary REST connections to IHS and South Dakota's health department. That eliminates manual data entry and cutting the lag time between us getting the data and it being available to the end users. Cloud Data Lake keeps the raw, cleaned, and analytics-ready data separated and traceable at every stage. And then a master person index deduplicates across multiple input sources and jurisdictions. We have a lightweight electronic disease surveillance system to configure workflows for over 80 reportable conditions, and even being able to add conditions that aren't CDC reportable but may be needed for custom tribal work, and both today and in the future. And it all runs on commercially available cloud storage, compute, and analytics. And so, that cloud storage and analytics platforms allows us to serve up these data pipelines and analysis tools to give us dashboards and things that the end users have access to. So, Nick, deduplication across the jurisdictions sounds simple, but it's notoriously hard. What actually makes the master person index work?
Yeah, so years of patiently learning what works best. We built the MPI on top of CDC's publicly available record linker solution rather than inventing matching logic from scratch. And then our team spent considerable time tuning it against our own data patterns. We ingested a massive import of birth to death person identifying information demographics from the Indian Health Service Registry, which includes tribal affiliation. This vastly strengthened the MPI and our row-level access controls for the 17 tribes. And you'll see some actual numbers behind this in a couple slides, but I want to say that the MPI user admin interface is also exceptionally strong, highly intuitive, presents on-demand full access to workflows and views, and allows every data element for merging to be seen and preserved.
Yeah, and I'll just go back to, just the experience that the team brings to the table. We were going over the MPI with another health jurisdiction and comparing notes, and John had done a quick turn of a really efficient sorting method to be able to compare new entries with the existing entries, and they were really just blown away by how that architecture choice led to efficiencies in search that really keeps the compute time down. So it's that broad experience that the team brings to the table that allows us to build for this web-based environment and be very efficient about it. So, from a question of what's most convincing, took the most convincing to get right, I would have to say for sure it was the EDSS without question. So engineers and analysts built every one of the pieces around how our tribal health directors, communities, epidemiologists are working today and will likely work in the future. So the case management workflows took the most iteration, and we're still iterating as we get new people into the system. But we keep going back and saying, how is this workflow going to match the way you're going to do your job in the Great Plains area? And we'll keep adjusting until we get it right. So when there weren't clear answers, we relied on the team's experience to build and deliver an EDSS solution that's future-proof for our end users. So here's an overview of the platform. Unlike the remaining screenshots, this is a full production. So this represents the data that is in the system. roughly 143,000 cases and 300,000 persons with multi-source deduplication already running. So the cases come in from the South Dakota Department of Health or the electronic lab reports, and they get matched against the IHS registry and reconciled with each other. So if there's a lab report and a case report that have the same core information, those are put together as the same person and then the same lab. And then we are able to use the IHS registry to overlay more information about demographics and tribal identity automatically. And this is built to add more. So we've built this so we can add more sources as soon as the data use agreements are in place. And in fact, we just started integrating vital statistics, which are birth and death records from one of the tribal jurisdictions that we serve. And we have a project outlined to take in a full state immunization registry when that becomes available to us.
Yeah. And being able to maintain this with less than 2% queued deduplication of persons in the last month represents the team's depth of experience and the power of using web-based architecture and taking the CDC's publicly available record linker and building out the winter count master patient index around it. We also have plans to further refine the algorithms for the population we serve. For example, unique to this population are indigenous or given names. These names often make use of common attributes of the Native American culture, names like maybe Charging Bear or Red Hawk, and sometimes they can be numerous even for a single person. They are not just alias names, they are names integrated with the community. We think that the CDC algorithms can be improved beyond the typical SoundX or the simple addition of alias names to an algorithm to really recognize and maintain the links between these diverse name sets for the same person.
And so that under 2% number, is that where we started, or did it take real tuning to get it there?
It's nowhere near close to where we started. The earlier versions flagged duplicates far more aggressively, which meant investigators were spending time manually reviewing matches that should have resolved automatically. Also, the tools have been streamlined to help admins resolve potential duplicates more quickly. We're now resolving potential duplicates in under 5 minutes. Getting it down this to this time took multiple tuning passes against our actual data, not a one-time configuration.
And we're also looking forward to incorporating methods that have been used to clean different epidemiology data sets and other methods that have been used, as well as looking back and doing some machine learning on what we've done already to make it adapt and be more efficient going forward. So it's really exciting part of the tool that kind of hides in the background.
So a bit about governance and security. Governance isn't bolted on here, it's first. Tribal data sovereignty, honored through policy-driven data sharing rules, sits at the very center of everything our team designed.
And Nick, role-based access down to the tribe, jurisdiction, or condition sounds great in theory, but can you give a concrete example of who actually sees what?
Absolutely. A tribal health director will see full case level detail for their own tribe. Unless two or more tribes have an agreement to share certain records, they will see nothing else. They can also download or upload their own data. They can see reports filtered to their tribe. And a general user that's non-tribal needing access to reports might see only de-identified aggregate trend data across multiple jurisdictions for situational awareness, for example. But they will not see the underlying identifiable records of a tribe that hasn't authorized that level of access to that individual. So the permission boundary is enforced at the system level and not left up to an honor system. Ryan, on the audit logging side, I was wondering, has a tribe ever actually asked to see their own access logs?
Well, we did have an experience where we had a brute force login, so an outside actor trying to break into the system. We had it fail at the multi-factor authentication level. And so we reached out to the user thinking that it was a failed login attempt. And they said, I never tried to log in. And so from there, we were able to go in and really look at what had happened and make sure that no one had accessed any data that they shouldn't have accessed, that they weren't able to get into the system. And so we look at these logs on a regular basis, and we are able to hand the complete accurate log over whenever we need to. So Um, we haven't had a lot of requests to see who's viewed what data, but we are looking at it and anticipate people wanting to see those logs, and we're trying to make them as visible possible so that we can uh, turn the trust us into something a tribe can actually verify for themselves. So this is our case investigation summary, built and shown here with test data. In this environment, it has over 60,000 cases that we generated for test data across every reportable condition, and then broken out by country, age, gender, and race, and then mapped geographically. We're in the process of adding heat scoring here so that we can see where there are disease trends that are spiking or waning, to really help dig through the data that's here. But this all started with our chief public health officer sharing the different types of data analysis they would do on a regular basis to look at an outbreak. And so, we started to build custom dashboards for a handful of diseases and conditions. And what we realized is that we could build one dashboard to really cover all of the acute diseases in one place. So we didn't have to build a measles dashboard and a chickenpox dashboard. We could have one dashboard that really covered everything. And so what you see is all the data here. In the next couple of segments, we'll show you how you filter this down to real actionable insights.
Mm-hmm. Yeah. And Ryan, this gives our health director something they've never had before, which is a real-time whole or complete picture look at disease burden across their communities. Um, Ryan, I wanted to ask, how many iterations did the team actually go through before landing on a view like this?
Yeah, so I think we went through 4 or 5 different iterations before we realized that we could build something like this and load all the data. So it took us a couple of months, but once we got there, we were able to quickly build out an all-case dashboard, and now we're going back and producing more specific insights and dashboards that really help people um, narrow this broad picture down to something that's really meaningful for them. So here, for example. We've applied filters to limit this to common STIs, so chlamydia, gonorrhea, and syphilis. And the reason, some might think you could put something like HIV or hepatitis C in here as well, but because those are chronic diseases, their timing and their epi curves don't really align the same way. And so, as what we're learning as we go through this is, how to really blend the knowledge of epidemiology that the team brings with the modern data tools that we have access through this cloud infrastructure.
Mm-hmm. Yeah, and surveillance has historically been so under-resourced across Indian country, certainly the same way COVID surveillance had been. And now being able to filter and drill down like this instantly is the exact kind of visibility our communities have been asking for situational awareness, early event detection, um, monitoring of long-term trends, and evaluation of program effectiveness in being able to reduce the burden of these diseases.
And so why pick STIs as opposed to another condition or group? How do we prioritize the disease models that we built?
Sure, sure. It's because it's a real persistent gap and not a hypothetical one. STI surveillance has been chronically under-resourced in Indian country for a long time, and much the way we saw with COVID surveillance before 2020. Showing that we can filter into specific burden in seconds instead of requesting custom report and waiting weeks for that delivery is the clearest demonstration of what the challenges and changes are that future DIS investigators will benefit from.
Okay. And so from here, we can then go into look at a specific uh, epidemiology curve. So again, this data is mocked up data that we loaded into the system. So look at this jump starting in late 2024. To be clear, it's not a real outbreak. It's an artifact of the test data that we generated for this recording. So you can see here, we have very little test data, and then we manually generated some test data, and then we got a boost with artificial intelligence and the public health AI collaborative teaching us how to use tools to build test data. And so what you're seeing here is an acceleration of our test data, not disease burden. But it shows you how you can quickly see and share trends over time. So if you were to see this as a particular disease, you would see that as an outbreak and you could respond to it.
Mm-hmm. Yeah, Ryan, we've been able to use these tools already to confirm real outbreaks And because we have links between cases and contacts, we can watch and see the spread from one tribal community to across to another. And this kind of surveillance has provided broad investigation support with alerting and notifications, which we have set up for certain diseases or for certain thresholds of diseases to give early detection of new cases or increasing trends or clusters and outbreaks. And we're still refining the tools for today's users, but the underlying visibility is already doing some real work.
Yeah, and without saying anything sensitive, can you say a bit more about what a real outbreak use actually looked like?
We certainly have seen, for instance, regional spread of pertussis or whooping cough in a community. We watched that transition or transmit across tribal jurisdictions. And really, I think the reason for this kind of capacity here is speed. Instead of waiting on a manual report from a state health department to notice a trend that was building or forming, the curve surfaces it automatically in real time, which means our team can start asking those hard questions right away and coordinating responses days earlier or weeks earlier than old processes allowed. Some processes didn't even allow the detection or notification of an outbreak.
Yeah, and we've even started to build some alerts into the system, right? We have some alerts
Absolutely.
already built in for pertussis, for measles, looking for any active measles cases popping up. And we're continuing to work with the tech to define future needs for alerts and really hone in on that sensitivity, right? So we don't want to have false
Yeah.
alerts, but getting it right to alert people ahead of time.
Yeah, we focused on alerts for vaccine preventable diseases or diseases of high consequence, and also environmental conditions like children under 6 with an elevated blood lead level.
Oh, great. Thanks, Nick. Okay. And now we can filter down from that working from that epidemiology curve. We've identified maybe an outbreak, and now we want to look at a particular line list for our investigators to use to assign the cases to just really understand what cases are at hand in a particular outbreak or a condition that we're interested in. Nick?
Yeah, before winter count, this list lived in spreadsheets on paper and things that were maintained by hand. This team here eliminated all of that manual processing just entirely. Now, whatever report parameters you search for and view, you can click a button and see the corresponding line list with a single mouse click in this view.
So, Nick, before winter count, how long would it typically take an investigator to even get a list like this by hand?
Well, I guess realistically, it could depend on a day or so, be anything beyond a small caseload. And that's before accounting for things that have to be done administratively in the background, like deduplication and error checking. When you're stitching together spreadsheets from multiple sources by hand, it just takes a lot of time and entropy out of your response time. This list isn't just always current, it's automatically available. Accuracy does require us to keep on top of person and case duplication, but that's done at a federated level of the MPI and not being done by hand for every individual data set.
Yeah. Yeah. And so today, when that comes in, that case is updated immediately. We only update this report on a daily basis just to save the compute power. But if we wanted to, we could update it more frequently, and we're evaluating that as we go forward.
Yeah, those REST API Delta interface, for example, with the state allows an 8 millisecond lag time between not only any records that are being created at the state level, but modified in any way. We're immediately getting that information.
Yep. Thanks, Nick. Okay, and so from that line list, we're able then to click directly through. And again, this is test data, but we're able to click through into a record, and we're able to see a full case investigation form with administrative, clinical, risk history, labs, interviews, referrals, and treatment, all in one workflow with the person level deduplication already checked. And if it hadn't been checked, you could go up here and look and make sure that it had been done and see if there are other cases that need to be looked at that are related to this.
Yeah, and the flexibility of off-the-shelf analytics powered by, for example, Power BI with a custom-built electronic disease surveillance system lets us customize all the views to how tribal health directors, their disease intervention specialists in the future, and their community health workers would actually get their work done.
So who actually uses this form day to day, and how much input do they have designing it?
Well, there are some disease intervention specialists that are using the system. Community health workers use this view, and tribal health directors review and act on what comes out of it. Adoption is slow. We're just getting started in this domain. But at the same time, none of this was done in a vacuum. Every section came out of listening and learning how the tribes actually worked, and then adjusting the forms and the models until every the need was met, not the other way around.
Yeah, and we've already had user feedback. We've implemented some of that user feedback in terms of um, having lists get shortened when it's not appropriate, given certain responses in the questionnaire. Having a simplified view for a community health worker that may not include all of the full details of a case, but still being able to access all the full details for a deeper investigation. And so, as these disease investigation specialists and programs come up to speed, we'll continue to refine this. So, we get to learn from the experience that Nick and the rest of the folks have, but we also get to customize it going forward. So, Nick, the headline numbers, the cost is down substantially versus a traditional electronic disease surveillance system. We've dramatically accelerated the data prep time from what used to take weeks to hours or even seconds, depending on the data pipeline that we're looking at.
Yeah, Ryan, and trust is going up as people are understanding that there's long-term sustainability here. This isn't just going to be a flash in the pan. This is a solution that's going to be useful for many and for a long period of time. And our users, the people that are doing this work every day, report real confidence in the data. They have faster outbreak detection, shared analytics with local control preserved, and lower implementation risk from rolling this out incrementally, and even resilience as their staff turnover.
Yeah. I mean, one of the benefits of building on a modern architecture is that if we need to bring in new people, this is what folks are being trained on coming out of school today. So it makes it easier for us to backfill if we need to. So let's put a number on that behind the what does cost down substantially, Nick. Can you give us folks a sense of scale, even roughly compared to a traditional electronic disease surveillance contract?
Yeah, sure. Well, I won't put an exact figure on it, Ryan, but think in terms of orders of magnitude, lower cost, not percentage points. A commercial electronic disease surveillance contract that's sized for an agency of our size typically runs into significant licensing and maintenance costs every single year, on top of new requests and scope of work and also just general implementation costs. We are running this entire platform for a very small fraction of that cost on consumption-based cloud pricing because we're not paying a vendor's margin on top of infrastructure that we can run ourselves very efficiently, in fact.
Yeah, and that resilience point matters. A system that survives staff turnover is a system a small agency can actually keep.
And that's the one our users mention the most, unprompted when we ask for them what's different.
So for any PHA watching this and wondering if it applies to you, adopt a modular architecture, prioritize managed cloud services, embed your governance early, deliver value incrementally, and focus on your users throughout. Nick, I want to push on the managed cloud services recommendation specifically because this is exactly where we hear the most skepticism. We've talked to jurisdictions that went all in on cloud and watched their bill balloon out of control within a year. What's actually different about how we approached it?
Absolutely. There are a few concrete things beyond what I've already mentioned. We run on consumption-based capacity that can scale down or pause when it's not in use. We're not paying for infrastructure sized for our busiest possible day every single day. In fact, we put a governance gate in front of provisioning, so nobody on the team spins up new cloud resources without a quick cost check, in fact. We monitor spend against budget on a regular cadence with alerts, not a once a year surprise. And critically, we adopted incrementally ingestion, then analytics, then case management. So our cost curve has always tracked our actual scope, not some theoretical end state we provisioned for on day one.
Yeah, and so the lesson for the other jurisdictions isn't avoid the cloud. It's don't lift and shift onto it without rethinking how you pay for it. So
Exactly, Ryan. And if I had to rank our recommendations, embedding governance early is the one I'd put above all others, including the cost piece. Get your roles, your access tiers, sovereignty agreements, and data sharing policies defined before you build that single pipeline, not after. That's the one our team got right from day one, and it's made everything downstream, including the cost discipline, much easier to hold on to. There are always improvements for governance. It's never perfect, and change management is always notoriously difficult. But strong governance out of the gate helps set the whole system up for success. None of this happens without our Great Plains Tribal Health Executive Board, the Great Plains Tribal Epi Center team and data coordinating unit, and the support of the CDC Foundation's Workforce Acceleration Initiative grant, including the architect, our analysts, developers, product manager, and the Great Plains Tribal Health Board, who's shaped every part of Winter Count.
thanks, everyone.
Thank you.